Okay, can we start now? I think is already 1 and 5.
Okay.
Okay, so Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. Today, inshallah, we're gonna have 3 lectures. Okay, the first lecture is about the cardiopulmonary bypass, the basics and the components, and the it's everything related to the cardiopulmonary bypass as a basic knowledge. The second lecture would be a bit false about the cardiopulmonary bypass presented by Dr. Arnauf, and the last lecture would be about the left-sided bypass. Today we have, mashallah, 2 consultants, Dr. Shabir Shaha, he is consultant cardiac surgeon from King Fahd Medical City, and Dr. Hussein Amoudi, also he's a cardiac consultant cardiac surgery from Al Madina Center. I wish all for the presenter all the best, and hope if there is any question, just let it at the end of the lectures. So Abdullah, if you are ready, just go ahead.
Okay. Assalamu alaikum. Good afternoon, everybody. This is Abdullah Tabi, R4 cardiac surgery resident at King Fahd Medical City. Today, inshallah, our talk is going to be basics of cardiopulmonary bypass. So I will talk about basic components, mechanism of perfusion system, assembly and priming, conduct of CPP, monitoring the adequacy and safety of perfusion, and lastly, the weaning from cardiopulmonary bypass. So as a basic component, we have a venous cannula, which is draining blood from the right side of the heart to a venous reservoir. Then after that, the blood goes through the pump to membrane oxygenator and heat exchanger where gas and temperature exchanges. Then goes through a arterial filter where micro bubble filter can be done. Then through the arterial cannula through to the systemic circulation. So this diagram basically simplify the components and mechanism of cardiopulmonary bypass. We have venous cannula, it's draining blood from the venous system of the body into a venous reservoir. Then after that, the blood goes into oxygenator and heat exchanger. Then gas exchange occur and temperature changes with either cooling or heating the blood. After that, through an arterial cannula to the systemic circulation. Other components including the cardioplegia system or cardioplegia delivery system, where the responsibility for providing the cardioplegia solution for myocardial protection and arresting the heart through the aortic root cardioplegia line. Also, another component including the vent system, or for decompressing, complete decompression of the heart, either through the aortic root vent or through the LV vent, draining into separate reservoir and then to the main venous reservoir and follow the same consequence. Another also component including the cardiotomy sucker or pump sucker, we can drain open wound. So drains into separate reservoir, then goes to the same as venous reservoir. So this is the basic components of cardiopulmonary bypass as we described. For mechanism of the perfusion system, to achieve adequate tissue perfusion while bypassing the heart and lungs, the system must fulfill the following. Number 1, adequate venous drainage. Number 2, adequate gas exchange and appropriate pump flow. Principles of venous drainage: either draining by gravity or siphon effect. Reservoir must be below the patient and continuous column of the fluid in tubes. Amount of drainage depends on the CVP or intravascular volume and venous compliance. The height difference between the reservoir and the patient, the rate of drainage to venous return volume, like shuttering, resistance in tube and connectors. We have also augmented venous drainage or vacuum assisted or pump assisted, where a negative pressure is applied, usually -20 to -40 millimeter mercury, useful for peripheral cannulation and miniature circuit. Disadvantages: chattering, hemolysis, and increased risk of air embolism. Cannula size selection selected based on the required full flow and desired mean pressure. First required flow is calculated based on desired cardiac index. So flow equal desired cardiac index multiplied the body surface area. Second, select the cannula size which create a minimum line pressure to achieve good flow with less resistance and hemolysis, calculated based on pressure loss according to the manufacturer data. Venous cannulation axis, we have different venous cannulation. Number one, atrial or cavo-atrial cannulation. It's draining the right atrium and the IVC for extracardiac procedure or aortic valve, usually for closed heart, such as coronary surgery. Care must be taken during lifting the heart due to kinking of the superior cavo-atrial junction, decreased drainage from the SVC, and risk of brain edema. Direct or bicaval cannulation, single cannula for the SVC and another one for the IVC. For open heart procedure, need tourniquets to prevent bleeding into the field and air entry into the circulation. Femoral cannulation for emergency cardiopulmonary bypass institution or high-risk resternotomy, thoracotomy, ECMO, and minimal invasive surgeries. So we have different types of venous cannula. For atrial, we have number one, ball and socket, and two-stage single venous cannula. For peripheral, we have femoral and bicaval cannulas. Now coming for arterial cannulation. Importance of choosing adequate size of arterial cannula. Tip of the arterial cannula is the narrowest part of the circuit and generates high pressure differential between the cannula and the aorta. High pressure differential produce high velocity jet and turbulence at the tip of the cannula that might cause cavitation and shear injury in the aortic wall, risk of dislodging atheroma or sandblasting, and also risk of dissection. Pressure gradient more than 100 millimeter mercury between arterial line pressure and aortic pressure can cause significant hemolysis. We have different types of arterial cannula. We have the straight, beveled, and the curve. Most commonly used are the straight cannula with an outer tip. Techniques of ascending aorta cannulation. Choosing appropriate site for an intended surgery away from calcified plaque, leaving space for cross-clamp, proximal anastomosis, or aortotomy. Double bear string technique to ensure stability. Position head down, asking the anesthesiologist to lower systolic blood pressure below 100 to decrease the risk of aortic dissection. Clearing the adventitia, stabbing and inserting the cannula while controlling the bleeding by finger or holding the adventitia with forceps. Ensuring the intraluminal position by observing the pulsatile column. Snaring and fixing the cannula by heavy tie, then de-airing and connecting arterial line, and ensuring intraluminal position again. A line pressure equal to the arterial pressure, then fixing the cannula to the skin is helpful to minimize the tip movement and intimal entry. Femoral artery cannulation, first choice for emergency cannulation for severe bleeding, redo, pre-op cardiac arrest, intra-op dissection, and post-op severe shock. Electively can be inserted in MIS surgery. It can be done either surgical cut down or percutaneous. We have also another technique, axillary artery cannulation, preferred over femoral cannulation for aortic dissection repair Advantages is free from atherosclerosis, the axillary artery, provide integrated flow to the arch vessels, and protection from arm ischemia by collaterals. Coming to the venous reservoirs, we have rigid and soft. Rigid advantages is facilitate volume measurements, easier management of venous air, easier to prime, large capacity, provide emergency volume, less expensive. Disadvantage, more risk of microemboli, blood elements activation. Soft advantage include eliminate blood gas interference and reduce chance of massive air embolism. Talk about oxygenator principles. We have a principle of oxygen and carbon dioxide diffuse passively between the blood and gas through a membrane according to a pressure differential. Partial pressure of oxygen is mainly controlled by FiO2, while partial pressure of CO2 by gas flow rate of the sweep. Membrane oxygenator compared to bubble oxygenator advantages, less particulate and gas emboli, less activation of blood elements, superior control of blood gases. Heat exchanger, hypothermia is used in cardiac surgery to decrease the oxygen demands and to provide bloodless field during hypothermic circuit arrest. Perfusate temperature is controlled by passing hot cold water through coils around the blood in a heat exchanger unit. Blood should not be heated above 40 Celsius to prevent denaturation. Temperature gradient between brain and perfusate should never exceed 10 Celsius to prevent formation of air bubbles distant to the arterial filter. Pumps, we have two types, pump, roller pump and centrifugal pump. Centrifugal pump flow depends on impeller rotation speed and afterload, generate less negative pressure, less microemboli, while roller pump flow depends on length and diameter of tubing, rotation per minute of the RPM, compression of tube should be nearly occlusive. This table summarizes the difference between roller pump and centrifugal pump. Roller pump mainly nearly occlusive afterload independent, advantage low prime, the volume low cost, no potential for backflow shallow, while disadvantage excessive positive and negative pressure, tube rupture potential for massive air embolism, and require close supervision, while centrifugal pump non-occlusive, afterload sensitive, portable, position sensitive, and safe positive and negative pressure, adapts to venous return, superior for right or left bypass. Disadvantage including large prime time, requires flow meter and potential backflow, and high cost. Filters and bubble traps. Microemboli can be generated from anywhere in the circuit or in the open wound. Gaseous, biological or non-biological microemboli produce much of morbidity associated with the CPP. Largest source of gaseous microemboli is the cardiotomy reservoir. Other sources of gas emboli include stopcock, sampling ports and injection sites, priming solution and procedure, cavitation in the pump or aortic cannula, low volume venous reservoir, oxygenator tears or break in the tube, loose bare string, and rapid rewarming. So this table summarizes the major sources of microemboli. We have gas from public oxygenator, cardiotomy reservoir, air entry into the circuits, and cavitation. Foreign body including atherosclerotic debris, fat, and fibrin clot. Blood including free fat, aggregated platelet aggregates, and hemolyzed red cells. Prevention and control of microemboli. From perfusionist side, using membrane oxygenator instead of bubble oxygenator, using cardiotomy reservoir filters, arterial line filter. From surgeon point of view, minimizing the field suctioning, washing the blood aspired from the field, appropriate LV venting, and de-airing. Perfusion monitors and safety devices, including backup heater, cooler, backup oxygen supply, emergency lighting, pre-bypass ACT during bypass, pre-bypass checklist, macro bubble detector, arterial line filter, pre-bypass recirculation and filtration, oxygen supply filter, inline venous oxygen saturation, inline arterial oxygen saturation. Now coming for assembly of the pump and priming. Assembly of cardiopulmonary bypass and priming. Dry setup takes 15 minutes and lasts for 7 days, while primed setup takes around 15 minutes and lasts for 7 hours. Priming and hemodilution. Priming solution takes around 1.5 to 2 liters of fluid. Priming solution decreases hematocrit by 30%. There is no consensus for optimal hematocrit during bypass, but most will be around 20 to 25 at a temperature from 25 to 32 Celsius. Managing hemodilution. Hemodilution should be managed to keep mixed venous oxygenation above 60% to assure proper oxygen perfusion. If the mixed venous below 60, it can be fixed by transfusion to increase the hematocrit, increase the pump flow. Mannitol can be added to the prime to stimulate the diuresis and minimize post-op renal dysfunction. Decreasing the hemodilution can be done by shorter lines, smaller diameter tubes, decrease priming volume, and wrapping or retrograde autologous blood priming. Hemofiltration using semi-permeable membrane connected to the arterial line after the pump, generate enough pressure for filtration, remove water from perfusate and reduce hemodilution, and remove excess electrolytes, drain back into a venous reservoir, conserve platelets and clotting factors. This is a picture for the ultrafiltration. Now coming for heparinization prior to bypass. Heparin augment antithrombin 3 by 1,000 folds. Initial heparin dose including starting from 3 to 4 milligram or 300 to 400 international units per kilogram. Bovine heparin is more antigenic than porcine. Recommended ACT for initiation of the bypass is 480 seconds, 300 for cannulation. High ACT increase the risk of remorse bleeding or heparin rebound. Low ACT risk for clotting. ACT is measured every 30 minutes on the bypass, and half of the initial dose of heparin is given every hour to maintain adequate anticoagulation, even if the ACT within the normal range. Failure to achieve satisfactory ACT, either inadequate heparin dose or low antithrombin 3 or heparin resistance, is most commonly caused by previous exposure to heparin. Treatment for heparin resistance, including giving extra dose of heparin, total of 5 milligram per kg, and another modality, antithrombin 3 replacement, either by FFP or recombinant antithrombin 3 preferred to avoid transfusion risk. Heparin reversal by protamine, 1 milligram of protamine to 1 milligram of initial dose of heparin, and cardiotomy. After protamine injection, cardiotomy suction is discontinued. Heparin protamine complex activation pathway may cause hypotension, may be avoided by giving calcium. Now, for initiation of bypass, once cannulating secured and anticoagulation is adequate, CBP is initiated. While initiation of the bypass, you have to observe 6 things. Number 1, adequate venous drainage for desired flow. Number 2, decompressed heart. 3, arterial line pressure and arterial line oxygen saturation, systemic arterial pressure, and systemic venous pressure. Once the full flow, wait for 2 minutes, then stop the ventilation. start to cool down and cross-clamping the aorta. Troubleshooting for low venous drainage, inadequate drainage management from surgeon side, pre-op choosing of adequate cannula size, appropriate position of the cannulation, ensure there is no kink or airlock in the tubes, ensure there is no unnoticed external bleeding, especially in the pleura. Perfusionist, ensure height differential between the patient and the pump, at least 4 centimeters for adequate siphoning. And you can use assisted venous drainage system like pump or vacuum, which again increase the risk of microembolism and hemolysis. Anesthesiologist side, increasing the volume by fluids or blood, decreasing the venous tone by medication. For arresting the heart, antegrade cardioplegia started with a pressure around pressure of 60 to 100 millimeter mercury for adequate coronary delivery. How to determine a sufficient cardioplegia? Amount of cardioplegia, arrest the heart within the first 100 ml, cessation of electrical activity, arrest time 30 to 60 minutes after the administration. Failure to arrest with antegrade, either problem with cardioplegia solution, problem with cardioplegia delivery, or unrecognized aortic regurgitation or proximal severe stenosis in the coronary, loose aortic cross clamp. For retrograde cardioplegia, an important thing to know is provide incomplete protection of the RV. Adequate retrograde cardioplegia parameter, including pressure from 20 to 40 millimeter mercury and flow from 200 to 40. Arrest time between 2 minutes to 4 minutes after the administration. Make sure that high pressure the cardioplegia line may cause injury to coronary sinus. Low pressure may indicate insufficient delivery caused by coronary sinus tear or rupture, malpositioning of the retrograde line, leakage around the balloon, or loose bursting. Cardioplegia delivery system, line for cardioplegia solution, line for oxygenator for blood, pump for each line, cooler and heater for also rewarming, filter pressure transducer, and line to the patient. Venting the heart, myocardial oxygen demand depends on contractility, heart rate, and wall tension. Wall tension equal the pressure multiplied by the radius divided on 2 multiplied the wall thickness. Without appropriate venting, the arrested heart fills and distended, increasing the both radius and pressure, increases the LV wall tension and oxygen demand, and causing ischemic injury or irreversible injury due to myofibril disruption. RV is a volume chamber and distension is rarely a problem. So sources for blood returning to the LV, either blood escaping around venous cannula, coronary sinus, and Trapezius vein, bronchial blood, aortic regurgitation, and non-coronary collaterals. Different sites for LV venting, pulmonary vein, most commonly the right superior pulmonary vein, left atrial appendage, and vent past retrograde through the aortic valve, pulmonary artery, and LV apex. Useful for emergency venting when cross clamp cannot be applied in case of porcelain aorta. Perfusion parameters. Safe organ perfusion during bypass depend mainly on flow rate, arterial pressure, hematocrit, and temperature. Accepted flow rate index is 2.2 to 2.4 liter per minute for average size adult, and at temperature from 35 to 37 Celsius, and hematocrit at 25%, deeply anesthetized and muscle relaxed patient. Flow rate temperature relationship, hemodilution decrease oxygen content from 20 ml per deciliter to 10 ml per deciliter, around 50%. To compensate for this, increase the flow limit, which is a limited option, decrease oxygen demand by hypothermia. For each 1 degree decrease in the temperature, the required pump flow index is reduced by 7%. Acceptable flow rate at different temperature to keep 85% of maximal oxygen consumption level at 30 Celsius, around 1.8 acceptable flow, while at 25 around 1.6 liter, at 18 Celsius around 1 liter. So this diagram summarizes the relationship between hypothermia and oxygen consumption. So we have at 20 degree the acceptable flow around 1.6, while 25 around 1.7, 30 around 1.8, and 37 around more than around 2 liter. Coming for MAP and oxygen perfusion, organ perfusion. Brain perfusion depends mainly on MAP, so keeping the MAP above 60 millimeter mercury, and if the MAP above 55, brain will keep its perfusion by autoregulation. But in special situation like elderly, hypertensive, and presence of peripheral vascular disease and carotid stenosis, patient needs higher MAP, so better to maintain it above 70. Higher pressure increases the collateral flow to the field. Other organs depends mainly on the flow index. If systemic flow reduced, the first organ will be affected by order skeletal muscle, then abdominal viscera and bowel, lastly the kidneys. For hypothermia, advantages of cooling: protect the brain and increases the safety of circulatory arrest, protect the heart, mainly maintain hypothermic cardioplegia, and protect the body by maintaining perfusion at lower flow and lower hematocrit. Disadvantages: decrease the enzyme function, decrease coagulation, decrease organ function, increase cardiac recovery time, increase systemic vascular resistance, increase the pump time, increase the risk of cerebral hyperthermia and air embolism, increase post-op depression and anxiety. For glucose management during the bypass, tight glycemic control with the blood sugar around 140 to 180 milligram per deciliter decreases the rate of infection post-op, neurological injury, renal injury, cardiac complication, ICU length stay, and overall mortality. For temperature monitoring, we have bladder or rectal. For body mass temperature, not for the brain. For esophageal and pulmonary artery temperature, usually it's affected by the local cooling and cardioplegia. Jugular venous bulb, best for brain's temperature, difficult to obtain. Nasopharyngeal or tympanic, more commonly used to assess the brain temperature. Underestimate jugular bulb during rewarming by 3 to 5 Celsius. For neurophysiological monitoring, including jugular venous bulb, temperature and mixed venous oxygenation, saturation, transcranial Doppler and ultrasound, NIRS, and EEG. Clinical benefit not yet has been established for routine bypass, but more commonly used for circle rest. Body perfusion monitoring depends on adequate oxygen delivery and consumption of oxygen. We have mixed venous saturation. Assess relationship between delivery and consumption. If it's below 60, indicate inadequate oxygen delivery. More than 60 does not assure adequate oxygen delivery due to difference in regional hypoperfusion. Lactic acid elevated level indicate inadequate oxygen delivery between even with normal mixed venous oxygenation saturation. Urine output, good urine output is reassuring but does not ensure a good perfusion. Urine output usually affected by the perfusion pressure abscess, pulsatile flow, temperature, medication like Lasix and mannitol, prime content, hematocrit, and viscosity. Now coming for weaning from the bypass, gradually withdrawn of extracorporeal support as the heart takes over the circulation. Difficult weaning from the bypass can be anticipated before the start of surgery, like in case of severe LV dysfunction, RV dysfunction, or pulmonary hypertension, acute MR, or recent STEMI. Anticipation of difficult weaning is crucial, means of mechanical circulatory support should be prepared pre-operatively, like balloon pump or ECMO. Weaning is a combined task of the surgeon, anesthesiologist, and perfusionist. The surgeon directs the action of the team depending on the stability of the patient, hemodynamics, and other physiological parameters. Before starting weaning, manage the following parameters. From surgical point of view, anastomosis, suture line, and hemostasis, de-airing. Physiological including temperature, electrolytes, hemoglobin, ABG, sugar, and urine output. Hemodynamic including rate, rhythm, and contractility. Rewarming starts usually before the conclusion of the surgery, commonly with the last anastomosis in CABG or before cavity closure of an open heart procedure. Use of vasodilator if tolerated may improve homogeneous rewarming and increase venous compliance to accommodate the circuit volume. Perfusate temperature max equal 37. Patient perfusate temperature max gradient equal 10. Temperature more than 37 is acceptable to come off from bypass. De-airing starts before removing of aortic cross clamp after open heart. Before the final closing stitch, air is removed by reducing the venous drainage, and the heart is continuously massaged to displace the trapped air. The closure is completed with gentle venting with the head down, and the aortic clamp is removed. De-airing after removal of cross clamp after open heart. Patient is positioned with the head down, with the left tilt to displace the air and apex anteriorly. Air is detected by TE and suctioned by vent. Entrapped air and pulmonary vasculature and cavity is displaced by Valsalva, shaking, and massaging. For electrolytes management and acid-base balance, potassium target 4.5 to 5 to decrease arrhythmia. Also, always prefer to keep it at the upper border. Lactic acid should be corrected. Hemoglobin above 8, blood sugar from 140 to 180, and adequate urine output. For rate, rhythm, and contractility parameters, contractility is assessed by visual inspection and TE. Regional abnormality may be due to air embolism, graft spasm, or incomplete revascularization. Global hypokinesia is maybe due to inadequate myocardial protection, reperfusion injury, or stunning metabolic acidosis. Treated initially with inotropic support, correcting reversible causes, and finally mechanical support. Rhythm should be sinus. Junction rhythm may be acceptable if there is no bradycardia. Causes and management of arrhythmia during weaning: defibrillation, first by basic paddles with a joule around 5 to 20. Simultaneously look for the cause. Check and correct hyperkalemia. Hypomagnesemia can be corrected empirically. Coronary acidosis, blood hotshot. Blood is a natural buffer, so buffer lactic acid and mechanically flush it from the coronaries. Causes and management of arrhythmia during weaning: coronary air embolism, treated by increasing CVP and keeping pulsatile flow by partially clamping the venous line and let the heart eject. Ischemic ventricular fibrillation, especially in left ventricular hypertrophy, such as in case of aortic stenosis. Lidocaine works best for ischemic VF. Amiodarone and magnesium can be added for persistence VF. rate for sinus bradycardia usually transient due to pre-op beta blocker or RCA lesion, AV nodal injury intra-op, treated by mainly by temporary pacing. After ensuring all mentioned parameters is satisfactory, the surgeon asks the perfusionist to reduce the pump flow and fill the heart gradually, and asks anesthesiologist to resume ventilation. At least 300 ml is kept in the reservoir for volume resuscitation, such as in such emergencies such as Brutami reaction to go back on pump. Extra volume is available from tubes approximately 300 ml and oxygenator around 250. While coming off, monitor the following: rate and rhythm, arterial pressure, pulse waveform, RV filling by inspection, and CVP. Confirm satisfactory native circulation and ventilation. Pulse oximetry should be 100, end-tidal CO2 above 25, mixed venous above 65. When cardiac performance is satisfactory and stable for a few minutes, remove the vent catheter and secure it. Remove venous cannula and keep snare initially for emergency volume resuscitation. Remove aortic cannula and secure. Give protamine, discontinue pump sucker. This was my end of my presentation. Any question for me or for Dr. Shabir?
MashaAllah, tabarakallah, Abdullah. Well done. So any question for Dr. Abdullah or Dr. Shabir? Or if there is any comment from Dr. Shabir he would like to add? I think there is an issue with the connection with Dr. Shabir, or just this is for me?
Dr. Shabir, we cannot hear you properly.
Yes, Dr. Shabir?
Yes. Can you hear me?
Yes, right now, yes.
Okay.
Actually, the connection is appear that it's not right. So if you can try another connection.
Problem. Hello.
Yes, Dr. Shabir is still the problem. I think is.
It seems there is an issue. There is an issue with Kabir in the connection. This
Exactly,
is Dr. Hamoudi. So let me just
yes,
comment.
Dr. Hussein. Welcome, Dr. Hussein. Sorry.
Until Dr. Shabir has good connection. So just to fill in the gap here. So Abdullah, you did an excellent job. This comprehensive and detailed information about how to initiate bypass and what are the basics that everybody should know. You did an excellent job. So it is very important for everybody to know the basics and how to get out of trouble. And then I know we'll talk about some scenarios, and then we'll have another discussion about every single case, and you will know what happened. And I want this to be more interactive for everybody to benefit. On the other hand, first of all, do you hear me okay or no?
Yes, Dr. Hussein.
Good. So something that you mentioned, Abdullah, the retrograde cardioplegia. There are people who basically use that, and there are people who hates it. They don't use it at all. And the main problem and criticism for this retrograde cardioplegia is basically the inadequate protection of the RV, which is not necessarily always correct. As long as you start at the very beginning with antegrade cardioplegia, and then you resume 1 or 2 times of retrograde, and you're sure that there is something coming from the right ostium, especially in the aortic valve replacement, and you don't go very deep because of those tributaries of the vein that comes at the very beginning. You don't cross them and occlude them, then you should have adequate protection. And I always add ice myself. And then people have different opinions about this. And everybody is basically comfortable with a way to do things. And everybody has his own cardioplegia for protection. Some of them, they will use blood. Some of them will use Del Nido. Some will use custodial and all that stuff. So as long as you're comfortable with something that works for you all the time, stick with it. And they're all good and they work very well. The second point in this presentation is the antegrade cerebral perfusion. Abdullah did mention the axillary cannulation, which is very important for every resident to know and to do at some point in time, because you will have cases of dissection or something that basically involve the ascenic aorta part of the arch, and you want to go on bypass sometimes before you open the chest or even after, but you have a graft in the axillary artery and then easy to cannulate the vein either peripherally or centrally afterwards. Something very critical for everybody to know, that the antegrade cerebral perfusion is very important when people are going to circle rest to protect the brain. And every resident has to know also the doses and how much we can give the patient. And normally the books will put like 10 to 15 ml per kg, which is for a person who is a 70 or 80 kilograms, going to be around, 1 to 1.5 liters, something like that. Some people, some of the big aortic surgeons, they like to give a little bit more, up to 20, which is very important. And again, there are some people also, which is a new era that's just happening for the past 2-3 years. People, they also protect the antegrade, which is the brain, and also they protect the lower body by putting like a cannula. Not a cannula, is basically a tube, just endotracheal tube inside the arch going into the descending, because it has a cuff, and they can perfuse the lower body and upper body and also the brain at the same time while doing the distal anastomosis. So these are important things for everybody to be aware of to complete this presentation. So you guys have to be very don't take the protection or problems with bypass as a light thing. It is very dangerous to not to have the basics and important things done properly for these, because you're going to lose the patient. You can stay as long as you want. You can do the operation that you want, as long as you are aware of the details and protect the heart properly. Take your time, no rush, do it right, and everything going to be good. Abdullah, you did an excellent job.
Well, thank you very much, Dr. Hussein, for your comment. Dr. Shabir is still there. Oh, I think he's not.
Hello,
Yes, Dr. Shabir.
you can hear me now?
Yeah, very clearly.
It is clear
Yes,
now?
go ahead.
Okay.
Yeah.
Sorry, I could hear you, but there was some problem with the audio. I think Dr. Abdullah, I just want to comment. Dr. Abdullah did a very good presentation. To be honest, he did not only basics, he did a detailed presentation. This is all what you need to know. This is enough, for as a practice. When you start your practice career, if you know this much, this is more than enough. Number two is the slides were very precise and very good, and very practical slides. No much theoretical, much I think every slide is very important. Every line is very important in this presentation to know. Only thing is that sometimes we have unusual scenarios happen in the OR. Like unusual during cannulation, you may have dissection. What you will do? There is an air in the line. What you should do? I think there are very which is very unusual things, and you may not see in your career, but you should know a little bit about these emergencies, how to tackle with them, like how to cannulate in dissection. These are unusual cases. So that is the only thing. Rest was an excellent presentation. If you have any questions, anything, you can go ahead. Hello?
Yes, Dr. Shabir. So, guys, if there is any question for Dr. Shabir or for Dr. Hussein, or even for Dr. Abdullah. Okay, I think there is no question. So, Dr. Abdullah, if you can share your slide. أهلا وعليكم السلام.
نادر على الإزعاج. أنا فيصل الغامدي. I have one question.
Yes, go ahead.
For any of the speakers. My question is about the aortic root pressure. I think you aimed for it to be around 80, but sometimes I hear higher numbers, and some of my teachers tell me that you should decide which pressure for the aorta based on your feeling, your tactile sensation. So if you feel the pressure to be low, and the perfusionist tells you that the pressure is 120, you should go higher until the pressure that you feel in the root is normal. Is that correct? Like, because the pressure cannot be 80, especially when the tubing is long, the cardioplegia tubing is long. But which number do you always target in the root pressure when you give the cardioplegia?
Okay, can I answer this question? Hello?
Yes, Dr. Shabir.
Yeah.
Go ahead.
So let me tell me the practical way what I do. So as you said, you're right. So there is a long tubing. So we usually say the aortic pressure is the perfusionist, which just tells us. I think usually I maintain more than 100 the pressure. When I start the cardioplegia, I give usually higher pressure. And if I have a left main and ostial RCA, I give a higher pressure to attain an cardioplegia rest as early as possible. Your heart should not beat long time because it may develop some ischemic changes later, may be difficult, may have dysfunction when you try to come off. So better make a high pressure. Like I do even a 150 of pressure. I ask the perfusionist, so he tells me I have 150 pressure, cardioplegia is going well, and how much volume it is also going. This is also important, not only the pressure. So the volume as well as the pressure are more important. So pressure I maintain like 150, even when the heart is arrested. Now the heart is relaxed, it should not distend. Watch the LV, and RV usually doesn't bother you, but LV, watch the LV distension. Manipulate the cardioplegia as per the LV. It should be very soft during when you give on cardioplegia. So once you have arrested heart is nicely, you see in a flat line, then you can come down with the pressure a little bit, 100 is okay. Maintain a volume of around that time, around 200. Even in the beginning, I would like to give a volume of more than 200 ml per hour, 200 to 50 ml. Then you can come down with 200 ml per minute. That is good, the volume. And then I usually give, there is no how much amount you give. So usually I give a 1400 ml. Some are good to give 1000 and then repeat it every 15 to 20 minutes. I believe that first dose should be more enough so that the heart cools down in every part, when you have particularly coronary bypass. When you have when your coronary is normal, then even a small amount, 1 liter is enough, and then repeating every 20 to 30 minutes is enough. So Why we should not give too much of high pressure? Because the root sometimes is atherosclerotic. You may give high pressure, and your needle cardioplegia needle maybe on the side, it may have some injury, some tear. That is why you should not give too much high pressure. Only in the beginning, then maintain around 1 to 120. I think 80 pressure, I do more than that. This is what I do in the antegrade cardioplegia. Hope I answered the question.
Thank you, Dr. Shabir. This is good. This is what I normally do. 140, 150 for the antegrade. I always, when I have critical left main, I don't only rely on the antegrade. I always add retrograde, at least at the very beginning, and just I remove it. I give one dose after I complete. Like I divide the dose sometimes, like because normally it's 20 per kg. So if you have a person who's 80 kilograms, like 1.6 liters, and then I give probably around like 900 antegrade, and then 600 or 700 retrograde. Retrograde pressure has to be a little low, like 60, 70 max. Don't do more than that. Even sometimes 50. And if I have an issue with the AI, and I know all the time the left ventricle is getting dilated, so I'm not protecting the heart properly. So the left ventricle in diastolic pressure is very high. So I always switch to retrograde after I give whatever I can, especially in the CABG patients. I give retrograde at least one dose. When I left the heart, I just remove it. I don't keep it anymore because people are afraid of causing injury to the coronary sinus. So I agree with you, Faisal, that we need a little higher pressure than 80, and then you feel it at the beginning. And sometimes the perfusion will tell you the pressure is okay here, 120, but it's soft for you. And you can see the oscillation. You see that it's not delivering. There is a problem. There is a mismatch. There is some issue with the pressure. It happened to me even yesterday. We go a little bit higher until we have a good pressure in the root, and then everything went okay afterwards.
It's clear, doctors. Thank you very much.
Okay. Any more question, please? All right. So please, Dr. Abdullah, share the slides on the group so everyone can get the benefits, the maximum. Inshallah, within 10 minutes, inshallah, we're going to start the second. Okay, so we're going to have a break for 10 minutes, inshallah.
How
Assalamu alaikum, everyone. Good afternoon. This is Amjad Bernawi from South Baptin Cardiac Center. I'll be today the second moderator for the session. So the second lecture will be presented by our colleague Nof Lamy from Medina Cardiac Center, which is about cardiopulmonary bypass, pitfalls, and management. She's gonna take us through wonderful scenarios and situations that we all can face in our residency program that we need to know and to have a scheme to how to deal with it. So please, Nof, go ahead.
Assalamu alaikum. Good afternoon, everyone. Thank you, Dr. Amjad. I would like to welcome Dr. Lamoudi and thank him for sparing the time to join us. So this is Nof Lamy, cardiac surgery resident from Medina Cardiac Center. Our topic for today is the pitfalls and management of cardiopulmonary bypass. Hopefully we can make this session as interactive and informative as much we can. So we'll go through each step of cardiopulmonary bypass, and for each step we will write some scenarios and how to act within them. You guys can hear me? Hello?
Yes, we can.
Yes, okay. So first of all, for each patient who will go for a bypass surgery, you need to have a comprehensive systemic-based history and physical exam to identify the history of stroke, renal disease, intestinal angina, respiratory problems, and bleeding disorders or peripheral vascular diseases. So regarding tests, pre-op, all patients should have labs containing CBC, PMB, coag profile, liver and renal function tests, HIT CT for patients with history of strokes, carotid Dopplex in case of history of stroke or bruise in time of exam, mesenteric Dopplex if there is an evidence of intestinal ischemia. Patient should undergo coronary angio by default for coronary patient, and in case of elderly patient who are going for valvular cases. And pulmonary function test in patients with history of respiratory problems like COPD and smoker patients. And chest CT should be obtained for any patient with evidence of calcification in the aorta and the chest X-ray. So our first case scenario. You are starting a mitral valve repair and ask the anesthesiologist to give a heparin. So you ask the perfusionist if the ACT is adequate for cannulation and bypass. He's having trouble and tells you that the standard dose of heparin has been administered, but the ACT is only 200 seconds and is not going up. How would you deal with this issue? What comes in your mind?
We should think of heparin resistance.
Heparin resistance?
Yes.
What do you mean about heparin resistance? What comes into your mind? What's making the ACT not boosting up with regular heparin dose? Can you be more specific? What is heparin resistance?
The same thing that the ACT is not going as expected.
Mm-hmm.
So in this case,
sorry, who's talking? I can't see names. So if you just introduce yourself before.
Yeah, I'm Tasneem R2 from King Faisal Riyadh.
أهلا Tasneem.
So in this case, we'll give another bolus of heparin.
Okay.
And to see if it's not going up, we might think of patient having heparin resistance. And we can give that fresh frozen plasma or factor 10.
Factor? What did you say? I didn't hear you, sorry.
Is factor 10 fresh frozen plasma or factor 10?
Factor 10. Okay, any other participants?
Yes, please.
What do you think?
Mohammed Al Aboud, R6, King Faisal, Riyadh.
High blood level.
So
Yeah,
I think what Tasneem is thinking of is right now. We already gave the standard dose, which is 2 to 3 grams of heparin to the patient, and after 2 to 3 minutes, we'll draw ACT level. Now, if the ACT level did not reach the level is required for either starting the suctions or to go and cannulate, we should supplement that with another boluses of heparin until we reach 6 to 7 grams of heparin. And that is where we made sure after 6 grams per kg to the patient, if the ACT did not go up, now we have to think of heparin resistance. And now there are differential diagnoses for heparin resistance. Either the patient had history of receiving heparin within the last 100 days, or whatsoever the reason, or deficient in the antithrombin 3 level in his circulation. There are multiple differential diagnoses, but this is what we think of. We have multiple line of options that we can treat such condition.
Okay, Dr. Ramoudi, do you have any comments regarding the answers?
Yes, I just joined now. So now you gave enough heparin and the ACT is still low, is that right?
Yes.
Okay, so did you ask for any other stuff like FFP, anything else?
Dr. Tasneem mentioned we might give FFPs.
Okay.
She also mentioned that we should consider the factor 10 administration.
Well, I mean, there are many other options. If there is an issue, then you have to give FFP, antithrombin 3, and then the other thing is you have to switch to something else if it's not adequate. Then we have bivalirudin, which is a hate to use unless necessary, and that's the least that you can use to do something else, basically, which is the way you deal with it and the way you administer it is not easy. You need to basically communicate with anesthesia, communicate with the perfusion, and they have to give it, and then every 15 minutes you have to check, and then it's not easy. And then there is also one time anti-10 was given, which is ergotraban, which is very bad medication to control the bleeding with, and I've seen it only once given, and unfortunately the patient bled, and the patient stayed for maybe 36 hours in the OR, not just 24 hours, it's 36 hours. And then at the end, PEs and DIC happened. But the heparin is the way to go. And if you can't do it, then FFP, and then you have to consult hematology to be with you, because you will need these medications to be monitored and dealt with. You have to be safe, and always, if you have a situation like this, ask another colleague to come and help you in the decision making every single time.
So our first scenario regarding anticoagulation: if inadequate ACT happens, antithrombin 3 deficiency results in the resistance of the treatment by heparin. And it's noted most frequently in patients maintained on preoperative heparin therapy or intravenous nitroglycerin, or those with high platelet counts. So in such scenario, the management would be first additional administration of 1 to 2 milligram per kg of heparin. And this sometimes is sufficient to boost up the ACT. If not, antithrombin can be provided by transfusion of fresh frozen plasma, or if available, a commercial antithrombin product can be used. So when it's prohibited for us to use heparin in case of HET, what is HET? Sorry. Can anyone tell me what is HET?
So HET is heparin-induced thrombocytopenia and thrombosis.
Okay. So what do you know more about HET?
What I know about HET is a complication of heparin therapy. And there are risk factors, there are certain precautions to keep eye on whenever we use heparin, to just make sure that the patient does not develop a HET. And there are a clinical period and clinical signs where we can notice this.
Mm-hmm.
And once we have the suspicion, there are like the scoring system 4T score, where we have to assign the patient, and if patient is intermediate or high risk, we can go for further investigations, blood test, including we have immunoassay, we have
Okay.
antibody level of the heparin BF4 complex.
Mhm.
And that's it. Once if the diagnosis has been confirmed that there is a positive study, and then we call it acute HET, and we have to stop the offending agent, which is heparin, and use alternative like argatroban and biliverdin as options. There are other options, and there are advantages and disadvantages for each of them.
Okay, perfect. So in case of you have a pre-op patient who has been on heparin therapy, how many days does it take for HET antibody to develop from the first time administration of heparin? Do you know?
You mean patient was not on heparin and just started on heparin?
Yeah, pre-op patient.
Pre-op
started
patient.
on heparin therapy for, let's say, acute coronary syndrome. How many days would it take for antibodies to develop?
Okay.
HET antibodies.
Okay. Now we have two types. We have transient drop of the platelet count, which is non-immune reaction, which is not clinically significant. And we have the type 2, which is the autoimmune induced heparin thrombocytopenia. So the typical timing is after exposure of heparin within 4 to 10 days of exposure of heparin, where we have to suspect HET.
So what I read that it's 14 days from the first time of or first exposure of heparin, patient might develop an antibodies for HET. But for patient known to have HET and has been cleared to be a HET by titers, and so how many days takes for HET antibody to develop for second exposure for heparin is 4 days. So just keep that in mind.
I see.
Okay. So thank you, doctor.
Thank you.
Any question regarding what Dr. Mohammed said? You guys understood? Okay. So HET is a condition associated with the development of heparin platelet factor 4 complex antibodies that binds to the platelet, triggering arterial and venous thrombosis. So in case of elective surgery, usually you are not in rush. You can postpone the case, wait to 2 to 3 months, and antibodies usually clear in less than 3 months. But in case of urgent or emergency surgery and patient have either acute HET or subacute HET, that are recovery from the positive recovering from thrombocytopenia. The use of unfractionated heparin alone increase the risk of rapid onset of HIT. Therefore, an alternative of anticoagulant regime is indicated, such as bivalirudin or tirfidam, as mentioned. Dr. Amoudi, any comments?
No, this is good. Just needed to go a little bit faster, so
yes, sure.
And explain and maybe ask question in each case. But yeah.
Perfect. So for next step for cannulation, we'll go through the steps thoroughly. First, you have to palpate your aorta for any calcification, not only the cannulation site, but throughout the whole ascending aorta. You have to ensure that you are high enough to complete all the proximal procedure, including aortotomy or proximal anastomosis. You need to ensure you are anticoagulated properly. Place your purse string, check for systemic pressure. At the time of cannulation, you need to be lower than 70 for systolic blood pressure. Cannulate the aorta and secure your cannula. How would you secure your cannula? Anyone?
Can I answer?
Yes, sure, please.
Can use snares. You can snare both of your purse strings and tie your cannula to the snares. The other way to secure your cannula is by using a suture and suturing the cannula to the skin. Another thing is by also securing it to the drapes with like a non-perforating clamp to the drapes.
Yes, thank you. So next, you have to check for your line, assess for swing and line pressure before giving the test for perfusion, and visualize the ascending aorta at the time of the test. Then you need to conclude your cannulation by cannulating your venous line, either by selective cannulation for intracardiac procedure or dual stage cannula from the RA. So the ABCs for this step is A for anticoagulation, B to be sure that you are high enough in your cannulation point, and C for calcification during palpation.
Sometimes you can't feel the calcium, and if you have a soft plaque, you're not going to be able to feel it. So that's why it is now standard of care, and it's class 2A indication to use epiaortic scan. So keep in mind, epiaortic scan is important. There are surgeons who are using this on a regular basis with every single case to protect themselves. Just get the probe from the TEE people. They will give it to you. There is a special, condom basically to do it, and then put either like water inside, and just check, and you will see the whole aorta, all walls, anterior and posterior and lateral walls. You will see where is the cannulation, so you can avoid it. So keep in mind, epiaortic scan is standard of care, and it's class 2A indication to do it.
Okay. So now your cannulation is completed. The perfusionist alerts you that there is a high aortic line pressure. What is your checklist in this situation? As you can see, if there's any evidence of aortic dissection, you need to check for your systemic pressure, if it's correlating with the arterial pressure as you communicate with the perfusionist, and if there is any evidence of swelling or discoloration in the ascending aorta. If there is no, you need to look for any obstruction in the arterial line, if there is any kink or clamp, and if there is malposition of the aortic cannula by palpating the aorta, and you need to check if the cannula is it small for the bypass or no. You are in adequate size.
Can I add something? Sorry, to the high arterial pressure. This is something I heard about a scenario. You know that the arterial cannula, not the AOPA, the straight tip one that you put, then you have to rotate it toward the arch.
Yes.
sometimes the rotation step can be forgotten and the tip could be toward to the aortic valves. And once you put your cross clamp, this happened with one of our consultant. He told me about this story. Once he put his cross clamp, he clamped the tip of the cannula. So this is something you have to make sure that the tip is toward the arch, and this is something that also can happen if you forgot. Thank you.
Okay, thank you.
That's a very good point he mentioned. Very good point. So, but there is a blue line. You have to align it with the aorta. When you use that cannula, you have to rotate. I mean, there's no way you don't do it. So you have to do it. I mean, very important. But sometimes you have the cannula against the wall. That's why when you put the arterial cannula, Yuba, some people, they go a little bit deeper. So the cannula can be a little bit flat on the wall. So it doesn't come like a 90-degree with the posterior wall. So this is a good point. Some people that clamp the cannula, that's very true.
So in case of iatrogenic aortic dissection, aortic dissection occurs in 0.01 to 0.09% of all ascending aortic cannulation cases. So the risk factor for this scenario is dilated ascending aorta, atherosclerosis, elderly patient, and high pressure at the time of the cannulation. So first, you need to visualize your aortic root and look for any dissections or discoloration or bruising. Immediately ask the anesthesia to perform TEE if you suspected for any dissection. TEE able to demonstrate an intimal tear in the ascending aorta of the cannulation site with the dissection flap that may extend proximally or distally. So what you would do in this scenario? You had an iatrogenic aortic dissection. What is your action?
Can I answer?
Please.
The first thing I will do is I will stop with the pump immediately. And then I will reposition my cannula. I will change my cannulation site. I will go for the femorals. It's faster than the axillary. And the procedure would change. I will do the main procedure in addition to Bentall procedure if I thought of dissection.
Okay, any other answers? Thank you, Dr. Faisal. Any other answers?
I do have, it's the same like Dr. Ghamti mentioned, but the thing is, the extra thing is when I stop the pump, I have many alternatives, but femoral is the fastest access, and usually it will not take a long time. And then I will go with deep hypothermic circulatory arrest. I will make sure that there is dissection or not. And after confirmation, then I can plan what is, whether I have to replace the ascending aorta and go for Bentall or only my primary procedure.
Okay, perfect. Thank you. So first of all, you need to call for help and stop the pump if the heart is not arrested. And in case of you already arrested the heart and then you suspected the iatrogenic aortic dissection, you need to wait and lower the flow, establish another peripheral arterial axis within the true lumen, cool the patient down, go to circ arrest with deep hypothermia, cross clamp and open the aorta and inspect for the dissection, and to evaluate if there is a need to replace the ascending aorta or no. So next, everything went smooth from cannulation.
Just wait a second.
Yes, doctor.
So this is important thing to have. Don't panic. Very important. Dissection, it happened to lots of people. Not the end of the world. It's a catastrophic complication to happen. If it happened right away after the cannulation, then you didn't start the pump yet. So just switch right away. Keep the cannula. Do not move it. Do not remove it. keep it in place. Go and open the groin and establish the bypass from there, and then cool the patient. Relax, cool the patient. That's number one. Go as low as you can, 18 degrees or 16 degrees, and then you can circle rest and then deal with that area. It's very simple. The key for the dissection is to where is the tear, which is the most important part. You exclude it and initiate or the continuity of the true lumen. That's what you need at this point in time, because the dissection happened only in one area, and it should be okay. You should be able to do only that area, that part, to replace the aorta in that area. But again, very important to calm and call for help. This is for the exam all the time. You do go and do the oral exam all the time. Like, call for help and ask a second opinion. Senior colleague, somebody who has more experience than you. This is a disastrous complication. Always do it, and don't say, well, I can deal with this myself. No, you need a second hand, almost always. Go ahead.
Okay. So initiation of bypass, you need to check for your ACT. You need to be more than 480 to initiate your pump. Go on bypass, check for your forward flow, and ensure that there is no obstructions. Empty the patient out, proper drainage of the heart once forward flow is confirmed, and hold ventilation at this point. Flush cardioplegia and specify your desired temperature, and complete any required dissection prior to cross clamp and arrest. For the ABCs of this step is ensure a proper ACT, hold ventilation, and ensure proper circulation with proper drainage. So our next scenario, mitral valve case is ongoing. Your perfusionist now tells you that there is a poor venous return and there is a drop in the venous reservoir volume after snaring the cable tapes. The right atrium is not distended. The CVP is elevated, and your perfusionist lowers the bypass flow to protect the level of the venous reservoir. What are some of the maneuvers to manage inadequate venous drainage? Anyone?
So it depends on the cause. Can you mute Tasneem?
Yes.
It depends on the cause. If you have already a low flow from the pump, then you're gonna have a low venous drainage return. I mean, to the perfusionist. If the cause is for example, the snares, for example, you have to check in that. You have to check in your cannulas also. Adjust your cannulas. Also, if the volume is not okay, the volume, if you don't have good full volume, something's going on. What else? Maybe the tubings, the cannulas, the venous cannulas tubing, maybe it's a clamp or something. It's like kinked, for example, or clamp. You have to check on all of those.
Okay. Thank you, Dr. Ayat. Any other participant? Okay. So in case of inadequate venous drainage, it can be detected by the surgeon as distended right part, or by the perfusionist as a drop in the blood level in the reservoir. First, you need to check for any airlocks, in the venous line. If there is no, ensure good position of the venous cannula. Elevate the level of the patient in relation to the reservoir, and use suction drainage. Maybe you need to upgrade your cannula size, reduce the flow as long as you still within an appropriate MAB range, and exclude other sources of blood flow into the heart, especially in the setting of distended ventricles, like aortic regurg. You might need to add a vent. In case of azygous vein, you need to adjust your venous cannula, and in case of left-sided SVC, you might need to snare it or cannulate it. Otherwise, you need to consider other site of volume loss, like retroperitoneal or peritoneal hemorrhage. You need to check for abdominal girth. When do you suspect this scenario? In case of extra volume loss, retroperitoneal or peritoneal hemorrhage, in which cases you might suspect this scenario might happen. Any idea?
Femoral cannulation.
Femoral cannulation. Like, can you be more specified?
So when you go on peripheral cannulation for the femoral vein, you may injure the vein, and then the bleeding may go to retroperitoneal.
Sure. In case of this patient had a femoral cannulation prior to your surgery, like he needed an ECMO or a balloon pump, or they had multiple attempts for femoral puncture or cannulation during the cath. Okay, so going further, after placing the aortic cross clamp and arresting the heart, the perfusionist alerts you that there's a poor venous drainage. You noticed a large amount of air in the aortic cannula. You are certain air has entered to the aorta and suspected that it has embolized to the brain. The level of the venous reservoir has gone down too low and the air has been pumped into the arterial line. What would you do at this point? Anyone? Do you understand the scenario, or? Okay.
So there is air in the arterial cannula, right?
Yes.
Yeah. So you have to stop the pump immediately. Okay. You can take the arterial cannula itself, and you put it in the. You stop the pump. You clamp both the arterial and venous lines. You ask the anesthesiologist to put the head down.
Perfect.
So you prevent more emboli, and then the arterial cannula. If you can aspirate, for example, the air at the sites of the cannula itself, if you can aspirate the air, then you do that. And then you put you remove the venous cannula, you put the arterial cannula in the atrium, okay, into this superior vena cava, and you snare it there. So you can give volume, and then I think we cool down and we protect the brain at that point.
Okay, perfect.
We go into deep hypothermic circulatory arrest. I mean, yeah. Yeah.
Okay.
So we can prevent more bubbles and emboli.
Okay.
And you put you do the maneuvers that you protect the brain with, like the ice packing and the medications and so on.
Okay.
Yeah. And then maybe you can check also with the echo if there is residual or something with the air. And then for the procedure per se, I think you cannot proceed for now. Yani. You can take the patient to ICU, protect the brain, and do the continue your management, and then you see whether you can do the surgery later on.
Okay, Dr. Amoudi, any comment?
Yeah, this is an exam question actually. So they always ask about this in the oral exam. It's a very common question to ask. I mean, she said it right. So most important part is stop the pump, clamp both sides, and let the blood come from the aorta. no problem. Just leave it open, no problem, and then switch that arterial cannula into the SVC and deliver. That's going to be a retrograde perfusion, okay, to the brain. So to flush the air, the debris, and then all going to come where? Going to come to the aorta. And then leave that hole open. So whenever you see things are good, so you can go back on bypass and then cool down. That's how you do it. And of course, positioning the patient and also anesthesia to go down, head down, and all that stuff. It's very important. Medications to use, and not so strong evidence for steroids and all other medications, barbiturates and all that stuff. But it does help sometimes. But use every single weapon actually to help the brain. But the most important part what matters is just flush that air from the brain by delivering the retrograde cerebral perfusion through the SVC, and then cool down. After you basically just de-air the lines and all that stuff, and you're good to go again.
Okay, thank you. So in case of air embolism, even for massive air embolism after initiation of bypass is rare complication. It has a high mortality and high incidence of neurological injury. It commonly happens if the blood level in the venous reservoir and oxygenator gets too low, allowing air to be introduced to the arterial circuit. So this is a simple algorithm in situation of air embolism. First, call for help. From a perfusion side, you need to stop the pump, clamp arterial and venous line, de-air the bypass circuit, and add necessary volume to the reservoir. From anesthesia side, they need to get the patient to the Tinderberg position, give 100% oxygen, add steroid, barbiturate, and mannitol, and support the circulation with vasopressor. So from the surgeon side, first you need to aspirate the air from aortic cannula and aortic root, give retrograde brain perfusion, reinstitute bypass, and cool the patient down for brain protection, and massage the coronary artery for de-airing, and complete the surgical procedure and de-air heart as the usual fashion. And after finishing the procedure by transporting the patient to the ICU, you need to consider deep sedation for brain protection and consider hyperbaric chamber.
Sorry, I have a question.
Yes.
Is the reservoir the only source of air to go into the arterial cannula, or we can have other sources?
Other sources for air embolism?
Yeah, embolization, yes, into the aorta.
What do you think, Dr. Mahmoudi?
Just ask the residents first, your residents first.
Anyone can answer?
Maybe during priming, the first time when the perfusion prime the circuit, maybe it's from the beginning, the tubings, or maybe there is some issue with the tube itself. Maybe it's leaking or something. These are
if it's leaking, blood will go out. But in case of air embolism, sorry, Dr. Ayat, the other source of air embolism into the aorta is mostly maybe the vent. Instead of sucking out the air, it might introduce air to the aorta. That's for
this is part of it. So the most important part is basically the air comes from the pump from somewhere, most of the time from the reservoir. People who are using suction all the time, but there is an air detector, and most of the air basically is not delivered, but there are some air that happen. If you have if one of the lines inadequate, I mean, you will see the air, but most of it coming from the right side of the heart to the reservoir, and then it will be delivered afterwards. And most of the time from the tube and from the perfusion side. I personally have never seen it happen at all. This happens sometimes in the big cases, not in the straightforward cases. And it depends on what pump do you use, centrifugal pump or roller pump. And it happened more in the roller pump than the centrifugal pump. So it's basically most of the time coming from the perfusion side. Coronary blower, that's Dr. Farid. I mean, CO2, we use that all the time. I personally use it for the bypass, when I do the coronary artery bypass, but never seen any problem with it. But it might happen. This is like something from outside, but everything is possible. But significant amount of air has to be something that enters into the circuit, and most of the time coming from the perfusion side.
Okay.
You see the air normally when you don't have, if your purse strings are not perfect in the SCC, in the IVC, in the venous, you will see that air comes to this is where you see it all the time in the venous system, and they can deal with it. They can deal with certain amount of air because they can, but a significant amount and sucking too much using the vac, it does cause problems. And if they have too much air, then that might be transferred to you in the arterial cannula afterwards. Yeah. Keep going if there is no more comments.
Okay. So after institution of bypass, your perfusionist cannot get the mean blood pressure above 40 millimeter of mercury. The anest is telling you that the patient has a high dose of ACE inhibitor preoperatively. What do you do next? What is this? And what is this case? Anyone?
Let me ask a question. Yeah, that's good. So, do you guys stop the ACE and ARB before surgery, and for how long?
It should be stopped, but in our hospital we don't.
You don't.
Yeah,
you don't stop ACEs, huh?
No.
Yeah.
In the usual
Have
practice.
you had any issues postoperatively?
Not all of our patients are vasoplegic usually. I have not noticed most of them being vasoplegic. Only the cases where they stay very long on pump or very low myocardial perfusion, low ejection fraction, or patients who have been even on inotropic support preoperatively. Those are the one I noticed to be, or the one with liver cirrhosis. Those are the one I noticed to be vasoplegic post-op.
Anyone else who don't stop ACEs?
Yeah, we don't.
You don't.
In our hospital in King Faisal, where I noticed that we continue, and we don't face that much issues during the ICU stay, so we keep them. Yeah.
Okay.
Okay.
Okay. So it seems that the majority of people are stopping the ACE inhibitor, which is what I came across all the time in every single book, also in the at least practice guidelines to stop those medications at 24 hours, almost around that number, at least one day before the procedure for possible vasoplegia. It doesn't happen all the time. That's very true. But if it does, it's a big problem. The only thing that we keep the patients on is beta blockers. They can have it the morning of surgery, no problem. But the ACEs, even sometimes drying the patients too much, Lasix too much, and antiarrhythmics all the time should not be stopped. But ACE normally we stop it. I mean, I've never seen anywhere that at least I get trained at not stopping the ACE inhibitor. But again, if you have good experience with it, then probably that's what you do and that's what you used to do. But wherever you read, you will see always ACE inhibitor should be stopped before surgery.
Okay, so to summarize this, vasoplegia can be seen in patients with numerous antihypertensive medication, specifically ACE inhibitors. In this situation, phenylephrine, norepi, and vasopressin, or even methylene blue are options that can be used to increase the systemic pressure. So next scenario, you place the coronary sinus catheter for retrograde cardioplegia because the patient has a moderate aortic regurg. As you start your retrograde infusion, the pressure within the coronary sinus seems to be very low. You inspect the inferior aspect of the heart to make sure there is no rupture of the coronary sinus or malposition of the catheter. You take out the catheter and inspect for balloon, it's intact. You place the catheter again and you confirm it's positioned well and by palpation. Despite this, the pressure remains low and the heart is not properly arresting. What are the causes of this problem? It has been mentioned earlier. Any idea?
It seems that not a lot of people using retrograde now, so.
Maybe because of if the heart is not arresting from the beginning, I would first make sure that the cardioplegia has proper amount of potassium. And maybe because of the retrograde is not enough to protect the whole heart. Is that the reason? If it's positioned very well and there is no coronary sinus rupture, maybe because it does not protect the heart very well. Maybe there is a. That's the only thing I can think of, actually.
Okay.
Maybe unroofed sinus.
I'm sorry, I couldn't hear you.
He said unroofed coronary sinus.
Yes. So in case of inadequate retrograde cardioplegia, it may be due to catheter displacement, but you already make sure it's properly placed. Rupture of the coronary sinus, we ruled that out. Balloon rupture, you need to take the catheter out and inspect it. And the last step, you need to consider a persistent left-sided superior vena cava. In this case, you need to place a snare or to occlude it, or even cannulate it separately. Okay.
Yeah, this is again the left SVC is an exam scenario, and it happened all the time. And the scenario normally comes to you as a patient that you're not able to arrest the heart. You give antegrade and nothing happened. You put retrograde and nothing happened. What is the next step? Normally, what's the next step is people always say, well, I'm going to open the aorta and just do ostial cardioplegia, which is the way to go. But if you just lift the heart a little bit and behind the main pulmonary, you will see that big SVC, which is left SVC. That's normally the answer, and they will take you to that route. But again, because it's going to be very big and everything comes to you, so you're not going to be able to deliver anything in that area. So you're not protecting the heart doing retrograde. The only way to protect the heart is giving antegrade cardioplegia. So this is a common scenario, and always they take you to the persistent left SVC. Keep going.
So throughout bypass, you need to check for asystole, proper arrest of the heart by clamping antegrade and retrograde plegia, venting the aorta, check for optimal pressure. In higher age, in patient with atherosclerotic burden, you may need a higher MAB than usual. You need to ensure that if flow is 2.1 to 2.5 liter per minute throughout the case. Assist perfusion for via lactate, venous saturation, and urine output. Cooling to mid-hypothermia may allow decrease the MAB as needed. And check for proper drainage. The heart should be empty throughout the case. And check for stats, ABG, oxygenation, and visual inspect of arterial blood. It should be bright blood all out the case to ensure proper oxygenation. So ABC for this step is proper asystole, breathing, which means oxygenation in this case, and circulation with good perfusion for the organs.
I think you meant here with the flow is you want the index to be like 2.1 to 2.4, not the flow.
Yes.
So normally flow depends basically. Normally you know that the BSA of the patient. How do you calculate the flow, by the way? How do you know the flow of this of any patient? Anyone knows how to, well, you have a 70 or 80 kilogram patient, what is the flow? How much you will flow is a full flow for this patient? Like, just do you take like 4 or 5 liters like haphazardly, or is there any equation that to determine these patients? Anyone has an answer? It was mentioned, if you think, if you pay attention to the first presentation of Abdullah, who was mentioned there.
To multiply the target cardiac index by the body surface area.
Beautiful, perfect. So what she meant, I think, here is 2.1 to 2.5 is the cardiac index. So there are people who, it's normally 2.4, what lots of people are using, but some people, they find 2.4, the field is flooded a little bit, and they go a little bit down to like 2.1 or something like that. But again, this is the number, 2.1 to 2.5 cardiac index. But the unit is different, not going to be like this.
So for oxygenation, inadequate systemic oxygenation can result in tissue ischemia and acidosis, and potentially resulting in multisystemic organ dysfunction. If the saturation is low, as is often noted during rewarming, this problem can be mitigated by improving the systemic flow rates or increasing the hematocrit. Evidence of cerebral oxygen desaturation is first evident by the cerebral oximetry, then by the pulse oximeter, and eventually by the systemic venous oxygen desaturation. Significant arterial desaturation may also result from a catastrophic problem requiring immediate attention, including failure of the oxygenator or the oxygen blender, or disconnection from the oxygen source. It might also result from the aortic dissection or malperfusion syndrome. Pump issue should be immediately recognized by the change of the color of the blood in the arterial line. So for summary and highlights of the session, patient undergoing bypass requiring a comprehensive workup to optimize the risk of perioperative complications. Phases of bypass including induction, maintenance, and separation. You need to be familiar with the critical elements of each of these phases. Air embolism, dissection, and venous perforation are major adverse events that can occur during bypass. Be prepared to anticipate and prevent and to deal with each of these complications. Poor drainage can result from air locks, inappropriate position of the cannulas, or simply persistent left SVC. An empty heart and poor drainage suggest loss of the blood volume. You need to think of catastrophic scenarios like retroperitoneal or peritoneal hemorrhage, then take in consideration. And these are my references. Thank you. Any questions or comments, Dr. Amoudi?
That's good. It's good to have an interactive discussion so people, they stay awake. not to keep their phone on silent and they go do something else. Thank you for all you and Abdullah for preparing these presentations, and for the participants to be part of this, which is amazing. To have people who basically have a good knowledge base, which is I find this today. Thank you very much, guys. I'm sorry I cannot continue for the next part. I'm not sure who's gonna cover the left heart bypass. Do you have any consultants with you guys?
No, unfortunately, we don't.
If you don't, I'm gonna stay, no problem. It's okay.
Yeah, it's a very short part or talk. It wouldn't take much time. It's just, yeah.
I will stay then.
Thank you.
Okay, perfect. So, guys, any question?
No questions.
Perfect. Thank you. Thank you all.
So just for the sake of the time consuming for Dr. Hussein, thank for him that he's staying with us. So we'll continue with the last part. It's a short talk about the left heart bypass. So stop sharing the screen, no, so I can.
أمجد.
أيوة رؤية تفضل.
Just before starting, I just want to announce that after this session, we'll have another session with Dr. Mariam Al-Umair, who's a locum surgeon at our hospital, King Faisal Hospital in Riyadh, about syntax trial.
Good.
Thank you.
Okay. Hi again, Salam Alaikum. This is me. Again, I'm gonna present the last part from our lectures for today instead of the additional one that I speak of. It's about left heart bypass. Again, I am Amjad, cardiac surgery resident at the Babtain in Eastern region. Actually, it's a very short talk that I couldn't find anything in the book يعني, talk about. So I'm really sorry. I hope it's gonna be beneficial. So left heart bypass. What do you mean by left heart bypass? Left heart bypass is uses of beating right heart to pump the blood through the lungs to provide a gas exchange only. So usually we use the left superior pulmonary vein and the left atrial junction. It's the excellent cannulation site, or the left atrial appendage. It's also can be used, but if it's not, but unfortunately it will be more friable. The apex of the left ventricle is infrequently used because of potential for myocardial injury. The tip of the intake catheter must be free in the left atrium, and careful technique is required to avoid air entry during the cannulation or perfusion. So, as an extracorporeal circuit of bypass, typically it's consists of only tubing and centrifugal pump. It does not include reservoir or heat exchanger or bubble trap like the full cardiopulmonary bypass. So this is to reduce the thrombin burden that may permit to reduce or to lower the heparin anticoagulation. Although we use heparin, especially in such surgeries like the deep circulatory heart arrest or the descending aortic surgery. Or even trauma surgery if the patient's taking as a trauma case. So to reduce the perfusion circuit preclude the ability to add the Quister fluid to adjust the temperature and to intercept the systemic air imply. Intravenous volume expanders may be needed to maintain adequate flow. Temperature usually can be maintained without heat exchanger. As I mentioned, only the centrifugal pump that we're going to use. Please, if there is any question or any comments, you can stop me at any point. So what are the types of the left heart bypass? So whether it's full left heart bypass or partial heart bypass. If it's full left heart bypass, it may be implement in left-sided coronary artery surgery to drain all the pulmonary venous return out of the left atrium and leaving no blood in the left ventricle ejection. So if the heart fibrillates or blood can still passively pass through the right heart and lungs, but often it's elevated, the central venous pressure is required to suck that blood. The other type is the partial left heart bypass, which is, as I mentioned earlier, it's been used in the descending thoracic aorta surgery. So this is to accomplish two goals by providing perfusion to the lower body beyond the aortic clamp, and to allow the perfusionist to remove preload as needed by increasing the flow. So thereby controlling the perfusion pressure in the proximal aorta, preventing both hypotension as well as hypertension and potential LV strain. So the patient's left ventricle supplies the blood to the aorta, to the aortic clamps, and the circuit supplies blood to the distal body, as I'm gonna show you in the picture in next slide. So typically about 2/3 normal basal cardiac output. It's about 1.6 to up to 2 liter per minute per meter square is pumped to the lower body. Arterial pressure is monitored by peripheral lines like proximal, radial, or brachial, and distal by femoral to the aortic clamps. Blood volume in the body and circuit assessed by central venous pressure, and TEE monitoring of chamber dimensions. So the management is more complicated because the single venous circulation and the separated arterial circulation. So typically this is what the left heart bypass, if you are seeing my pointer. So as we mentioned, one cannula is placed in the left atrial or in the left inferior pulmonary vein, and connecting the distal to going along to the centrifugal pump, and then to the distal descending aorta or the femoral, and sometimes like what we mentioned in the partial surgery, if you are going to do a surgery in the descending thoracic aorta or there is injury or trauma, so you place your clamp here and there, and you can just bypass the heart from here to there. Yeah, this is another picture that I found in the book in descending aortic surgery. Again, as I mentioned, you clamp proximally the aorta, you are placing your cannula whether in the pulmonary vein, I think in this picture, and then you place the other part through the centrifugal pump to the distal part, and you do your surgery. Again, here is the same while they are grafting the descending aorta, which is, to be honest, rarely been used, especially now it's TEVAR is replacing the descending aortic surgery. So that's why I think it's rarely has been used. And that's pretty much about my presentation. I'm really sorry. This is all what I found. I hope that Dr. Hussein have some comments or additional to add. My references is Lawrence Cohen and Bujar 6th edition. Thank you. Any questions, please? Any comments?
Thank you very much, Amjad. Yes, so left heart bypass. If you're doing a thoracoabdominal surgery, which is still has a place, the TVAR did not replace the whole thing. There are indications for TVAR, and there are indications for surgical thoracoabdominal replacement. So you can do TVAR for dissections. Still dissections you need to open, and again for like big aneurysms, there is no landing zone. If there is no neck enough, technically you can do the TVAR, the surgery. Still, everybody has to be familiar with the left heart bypass. So yes, you take the blood cannulation. What you mentioned is perfect. If you have a small area that you need to just exclude, you have to put the arterial cannula. Sometimes instead of putting it in the femoral artery, just put it more distal. If you have a normal distal descending thoracic aorta is normal and no problem, like something above the diaphragm, a little bit above diaphragm, you have an area that you can clamp, you can put the arterial cannula there and no problem. That's going to be for your distal perfusion. But if you have an extensive procedure and you need to basically use circle rest and cool the patient down, that's a different story. And again, when you do these procedures, you also need to perfuse the gut. And as you all know, there are big branches. You have the celiac artery, you have the SMA, you have the renals and all that, those vessels, and you go sequentially. Once you bypass one of them, you just put the cannula in it, and it's small cannula with, the retrograde. Some people, they use a small, they call it Gundry catheter, where you have a balloon, you pass it inside that vessel and you deliver. And then whenever you finish the anastomosis, then just connect and then give some cool blood to those vessels, sequentially perfusing them. Okay, we still it does have a role in the big thoracoabdominal abdominal surgeries. Most of the people, they just use femoral and they don't bother to do anything with the distal descending thoracic aorta or abdominal aorta. But again, if you have an area, some people that have a big aneurysm, like within 5 or 10 centimeters of the descending thoracic aorta, and you need to clamp above it and below it, and then that's not a problem. You can just place your cannula just distal, no issues. If you have a big redo and it's or a staged procedure, you want to see everything, then it's different. You need to cool down, and that's going to be a different procedure. But at the end of the day, it's used. Nowadays, yes, the use is decreased, not as before, because TVAR is taking a significant amount of our practice in the thoracoabdominal cases. Any questions?
Any question from the audience for me or Dr. Hussein Hamoudi?
And to you first, then I will come next because you're the expert, Amjad.
Yeah, that's what I said. To me or to Dr. Hamoudi. So I mentioned myself. It sounds like no questions.
Perfect. Then thank you guys very much for this nice discussion, and we're happy to come back again in one of these sessions.
Thank you, Dr. Hussein. I'm glad to. Okay, Luay, so sorry, remind me again that the next session is about
Syntax.
Okay, we're gonna take 5 minutes or 10 minutes break and then we'll resume.
Yeah, sure. So we'll start at 3:25.
Thank you.
No, sorry, 3:30, you said?
25. 3:25.
25, okay.
دكتورة مريم.
أهلا.
You can start whenever you want.
Okay. Initially, I'd like to introduce myself to you guys. My name is Mariam Al-Amir. I finished my residency and fellowship at University of Toronto, and I did my fellowship in pediatric cardiac surgery. So as such, I'd like to help and teach you guys in pediatrics and even in adult cardiac surgery as well. This session is meant to be directed to the R7, and it's semi-like journal club where we discuss a major landmark trials like Syntax trial that we discuss today. So I hope you guys had a time to read it and go through it so we can have an interactive session. Especially for those who are writing their exam this year. Did you guys were you notified about the session today?
Sorry, Doctora, what was the question?
If they were notified about the session,
yeah.
Did they prepare for the paper? Did they read it? Okay. And how many R7 do we have in this session today? They can raise their hand in the...
No.
Only 2? 1, 2, 3. Zainab, Luay, and Khalifa?
أيوة Khalifa.
Okay, so only 3 R7 today. Okay. All right, so we're gonna discuss the Syntax trial, which is an abbreviation of synergy between the percutaneous coronary intervention with the taxus and cardiac surgery. The taxus is the type of the drug-eluting stent that they use during the PCI for those patients who were enrolled in this study. Anyone can give me a brief idea about what was the study? How did they conducted the study? What is it about? What's the 2 major arms in the study? Zainab, Luay, or Khalifa?
So this is a randomized trial with 2 arms. The one arm is any patients coming with either free vessel disease or left main disease to be randomized to either receive a PCI or CABG. So it was published in 2009.
Okay. Okay, so the targeted patient, as you mentioned, Luay, patient with left main disease or patient with a 3-vessel disease who either went through a coronary bypass surgery or PCI. Those who went through a coronary bypass surgery, they have to have at least 1 arterial graft. And those who underwent PCI, they underwent drug-eluting stent, which is the first randomized control trials at that time to investigate or look at those people or those population who had a drug-eluting stent, as all the randomized control trials before there were testing the pyrimethamine stent. So in this study, it's a non-inferiority trial, and their argument is with the development of the drug-eluting stent, they were assuming that the outcomes for bypass with drug-eluting stent might be equivalent or at least non-inferior to a coronary bypass surgery for a patient with left main or 3-vessel disease. Okay. The primary endpoint was MACE. MACE is abbreviation of major adverse cardiac and cerebrovascular event as a composite endpoint of all-cause mortality, stroke, MI, or repeat revascularization at 12 months. That's the main primary endpoint of this study. They had an extended follow-up at also 3 years and 5 years, but we'll discuss all of them today, and we'll see how is the result propagate with the years. So the study design, as I mentioned, it's randomized controlled trials. They screened 4,000 patients. However, they enrolled only 1,800. The median follow-up was 1 year, 3 years, and 5 years. In terms of the inclusion criteria, it was very broad, so very few patients were excluded. Basically, any patient with three-vessel disease or left main disease or left main equivalent were enrolled. They have to have a de novo lesion with at least 50% stenosis and myocardial ischemia, but it has to be stable. So those patients who had acute coronary syndrome, acute MI, previous PI or CABG, any concomitant cardiac surgery were excluded. So if you'd look at the inclusion criteria, you'd imagine there's a lot of patients will be included or will be eligible to be enrolled in this randomized controlled trials. This one of the most important things and very important things to look at in any trial, that you have to look at the patient characteristic. Anybody want to comment from the table? What do you think? How balanced the patient between the two groups? Those who read the article.
So overall, there seems to be balance between both groups, PCI and CABG.
Mm-hmm. Okay, as you can see, age and body mass index, current smoker, previous stroke, blood pressure, all those things do you think that affect the outcomes? They have looked into it and they have matched those population between the two groups. So if you look at the p-value, it's not significant between the groups. So it's very well balanced population between patient between the groups. Same here for what you expect is may affect the outcomes like ejection fraction, the syntax score, Euro score, which is indicate the complexity of the coronary artery disease. It also shows no significant. The only few significant things between the two groups, it's time to procedure duration, and post-procedure hospital stay, which was significantly longer in coronary bypass surgery, which is expected. So it doesn't consider to be a bias between the two groups. Yes.
What about the complete revascularization? Isn't affecting the MAC?
Yes, so this is one of the things very important, and I pointed it's complete revascularization as you see, and it will be. I will show it even in the result. That complete revascularization was achieved more in coronary bypass surgery compared to PCI. Meaning, if they planned to do a 3-vessel stent, for example, most of the time, or 50%, they will not achieve the 3-vessel in PCI. However, it's more likely to do what you have planned to bypass during the bypass surgery. I will see how this will affect the result as well.
Yeah, very clear. Thank you.
In terms of the goal-directed medical therapy, they looked into the patient who underwent PCI and those who underwent CABG, coronary bypass surgery at that time, and they noticed significantly those patients who underwent PCI were very well medically optimized compared to those who underwent coronary bypass surgery. Aspirin prescription, discharge 1 month, 6 months, and even 1 year after were significantly higher in those who underwent PCI. Same things if they will look into any other antiplatelet medication, it's significantly more optimized in PCI patient. Same things with the statin, ACE inhibitor, and almost all the medication, except of the beta blocker, which doesn't show any significant difference between the two groups. So this is another hint to tell you how much those patients who underwent PCI, the cardiologists were medically optimizing the patient, and how this may affect the results or long term. Okay, as of a result, at 1 year, The MACE, which is the major cardiac and cerebrovascular event, as we can see in graph D, it shows significantly higher in PCI group. So the whole things, all-cause mortality, MI, revascularization, and stroke as a composite altogether were significantly higher in PCI group compared to coronary bypass. The difference was almost 5% difference between the two groups. However, they anticipated, given the diversity of the graft, that it may actually continue to grow and show more difference with time. If you look at the component of the composite outcomes, which is you look, for example, in graph A, death from any cause, there was no significant difference. P-value is not significant. If you look at the composite of death from any cause, stroke and MI, again, it was not significant. However, if you look at repeat revascularization here in C, it shows significant difference, which is higher in PCI group compared to CABG. So they concluded that what's driven or what drive the outcomes as a composite, it was the repeat revascularization. So no difference in all-cause mortality, stroke or MI. However, repeat revascularization was significantly higher in PCI, and that has affected the major composite outcomes at 1 year. Any questions so far? Okay. What makes this study very unique? They look into the syntax score. Anybody know what syntax score?
It's measure the complexity of the coronary artery disease.
Okay. How does it measure the complexity? What is it? How do they do it?
After coronary angio, you can calculate what is the syntax score according to the lesion. Where is the lesion? How many lesion? Is it proximal? Is it distal? So there's a criteria that you look into. That's how you calculate the syntax.
Yeah, so it's basically an objective assessment of the complexity of coronary artery bypass. Of coronary artery disease. So there's almost 11 components they look into in the coronary angiogram, and each of them has a certain number. So whether the vessels, the disease vessel is dominant or not, will give at some point. Which segment is involved, proximal versus mid versus distal, whether this is a totally occlusion or partially occluded, if it's at the bifurcation or trifurcation, if it's at the ostial, how tortuous the vessel, how calcified the vessel, the length of the stenosis, if it's more than 20 millimeter, if there's any thrombus, or if it's diffuse and a small vessel disease. Each of those components will give rank of numbers, and then they will calculate it, and then it will indicate how complex the coronary artery disease. And this is basically to make it more objectives rather than just like to look at it by your eye and say, well, this is a very complex coronary artery disease, or this is very simple coronary artery disease. According to the classification, they classify it into three categories. Low syntax score, which is any numbers between 0 to 22. Intermediate syntax score, which is 23 to 32. And high syntax, which is any score more than 33. So if they look into this study, how the result will affect according to the syntax score. So they look into the composite endpoint, which is the MACE, at low syntax scores, as we can see in A. The p-value was not significant. PCI or CABG were equivalent for those patients with low syntax score. With those with intermediate syntax score, they looked into, and again, it was not significant, PCI versus CABG. However, those with high syntax score, it was significant. So what they conclude at 1 year, that coronary bypass surgery is beneficial for those patients who are more complex, who have more complex coronary artery disease compared to intermediate and low syntax score. They continue to follow at 3 years and 5 years. And as we can see, and what exactly what they expected according to the shape of the graph, that at 5 years, the PCI as a MACE continue to grow up. So it's there's almost 10% difference. It's 37.3% versus 26.9% between PCI and CABG, and the p-value is extremely significant. That as of MACE, which is the composite again of all-cause mortality, stroke, MI, and repeat revascularization. They look into also the component of each of those composite outcomes, and what they found this time at 5 years, that almost all the components were significant. Repeat revascularization continued to be significantly higher in PCI. Myocardial infarction now became more significant with PCI, more MI found in those patients who underwent PCI. Death, stroke, or MI as a composite was also significant in those who had PCI. The only component that were not significant is the stroke, as we can see here. Bypass, so it's not significant, it's not higher, and all-cause mortality was not significant at this point. They did the same at 5 years, and they also tested the MACE at different, according to the syntax score. And what they found at 5 years, actually, a low syntax score, the MACE as a component was not significant. However, as a looking at each component, only repeat revascularization was almost significant. And those who underwent and those with low syntax score. However, in patients with intermediate and high syntax score, there were significantly, the MACE was significantly less or lower in the coronary bypass surgery. And if you would look at each component, all the components were almost significant in those patients with high syntax score, which is it concurred the same conclusion at the outcomes at 1 year, which is the superiority of coronary bypass surgery over PCI in patients with left main or 3-vessel disease, especially with those with high syntax score. Now, those with intermediate syntax score, they also had a superiority. However, it was not shown as all-cause mortality, but it was driven by the MI, the myocardial infarction, and repeat revascularization. So it's very important to know if you have a patient with left main or 3-vessel disease and their syntax scores is intermediate, one of the things you'd have to discuss it with the patient, and you have to tell it may not improve your survival in general, as mortalities may be the same. However, the risk of need second re-intervention with another PCI, or the risk of having an MI is significantly higher if they underwent PCI compared to coronary bypass surgery. There is no question of the superiority of the MACE at those patients who had a high syntax score at all the components, including all-cause death. So here, just to conclude again, those patients with low syntax score, there was no significant difference between the groups and the clinical endpoint at 5 years. However, those with intermediate score, 5 years rate of MI, repeat revascularization, and therefore the MACE were significantly increased in PCI group. However, they did not translate into a difference in mortality. Those patients who had a high Syntax score, all clinical endpoints apart from stroke were significantly increased or higher in PCI group at 5 years compared to coronary bypass surgery. This is further sub-analysis. With the study, they looked exclusively to those patients who had left main disease and see how their outcomes according to syntax score, and they found those who had left main disease and high syntax scores. A high syntax score, the MACE was significantly higher in PCI compared to bypass. However, it did not significantly change the difference between the groups in the intermediate and low syntax score, that with the left main disease. With the 3-vessel disease, according to the syntax scores, they found intermediate and high syntax score benefit had superiority with coronary bypass surgery compared to PCI, but not at low syntax score. This is just a sub-analysis group from the main trial. So conclusion from the trial, coronary bypass remained the standard of care of patients with complex coronary lesion, driven by favorable rate of MACE, cardiac death, MI, and repeat revascularization and CABG group compared to PCI group. Now, the big question here is, how does this trial affect the guidelines? When we read any randomized control trials or like any major trials, the big question after reading, we have to ask ourselves, how does this affect the guidelines, or how would this affect my practice? Any volunteer? Yes.
So what I understand that for guideline now, like if you have low score syntax for left main 3-vessel disease, PCI and CABG will be a class 1 indication. But if you have like intermediate or like complicated or high syntax score, CABG will be a class 1 indication, but the PCI will be class 2A indication. For the complex left main, the PCI will be a class 3. PCI will be a class 3, and for intermediate with 3-vessel disease, PCI will be a class 2A, and the complex coronary artery disease will be a class 3 for PCI.
Okay, so this is from which guidelines? Which guideline is referring to?
The American guideline.
American Heart Association?
Yeah.
Okay. All right. And so this is the AHA 2011 coronary bypass guidelines. So what you can see here, patient with left main disease, coronary bypass surgery is a class 1 indication. However, PCI, it's class 2A. And there is major, like, you will go through the components compared to stable ischemic or unstable. But with the big message is, if you have a left main, it's class 1 indication to go to refer this patient for coronary bypass because of the superiority of the coronary bypass surgery over PCI in left main disease. In 3-vessel disease, again, what we can see, it's class 1 indication for coronary bypass for CABG, class 2B for PCI of uncertain benefit. Okay, and this is the 2011 AHA guidelines, which we had until last year. The clinical update is 2021 AHA guidelines for coronary artery vascularization. Are you guys aware of this new update?
Yes.
Okay, so what's the new update? Is it Luay?
Yes, this is Luay. I haven't reviewed it yet, actually.
You haven't read it?
I did not review it yet. But
Okay. Did
from
you hear anything? Because yeah. Mhm.
Yeah, what I know from the European guidelines that the left main now is a class 1 for BCI as well. This is from the European guidelines. I'm not sure about the new updates on that.
Okay.
Okay.
Have you heard anything? Because there is a major change in the coronary bypass or the guidelines in 2021 from the discussion with the surgeon cardiologist in the meeting that you're attending. Have you heard any debate or any idea about what might be the change?
Yeah, which read about it. They are discussing about the stable disease, and they downgrade the CABG to class 2, and they upgrade the BCI in that subgroup of patients.
Yeah.
Also, they did not receive a complete revascularization, and which show here clearly in syntax, even in the law, they are going back to revascularize again and again.
Yeah, so this is a very important point. So even with patient with low syntax trials, even if there was no significant difference in the major or the MACE as a composite outcomes, we know repeat revascularization was significantly higher in those who underwent PCI. Those patients who had intermediate and high syntax score, for sure, we know that they benefit from coronary bypass surgery, right? And that's what we understood from the trial, right?
Yes.
Yeah, and those patients who had a high syntax score, either left main or 3-vessel disease, or the mix of both of them, they benefit from coronary bypass surgery at each point, like at each component of the composite. The all-cause mortality is significantly higher in PCI. If you talk about stroke, not stroke. If you talk about higher in PCI. If you talk about cardiac death, it's significantly higher in PCI. If you talk about repeat revascularization, it's significantly higher in PCI. So we understand how superiority of the coronary bypass surgery over PCI in those population, those who had intermediate and high syntax score. I'm not talking about low, but intermediate and high syntax score. But in general, we the message that the syntax score delivered, the syntax trial delivered. Okay, and the coronary bypass or the coronary guidelines since 2011 till 2021 was endorsed by this trial. And we know it's class 1 indication to do a coronary bypass surgery if you have a left main or 3-vessel disease. And it is uncertain, class 2B, to do a PCI of 3-vessel disease, and 2A for a left main. Okay. What happened in 2021 HA guidelines, patient with significant left main disease and complex coronary disease, if they're candidate for a coronary bypass surgery, it's still a class 1 indication. So they haven't changed the guidelines in terms of left main disease. However, when you come to multi-vessel disease, which is the 3-vessel disease, if they have normal ejection fraction, more than 50%, okay, they downgrade the coronary bypass surgery to 2B. And they make it equivalent to a PCI. So from this, you understand like how that could happen if the syntax score if the syntax trial with 3-vessel disease was superior in CABG in compared to a PCI for patients with left main and 3-vessel disease at intermediate and high syntax score, which is the majority of the population. So we want to understand how or why they downgrade the coronary bypass surgery patient with multiple vessel disease if they have a normal ejection fraction. So this is the major change in the guidelines. So if you go, sorry, if you go and see, you see a lot of articles and seeing why surgeon groups explain why they didn't endorse the new coronary artery disease revascularization guidelines. If you go through the guidelines and read the discussion part or the explanation for the downgrade of the guidelines, they will say based on the ischemia trial. Ischemia trial, anybody knows what ischemia trial? It's another major landmark trial that was recently published. It's basically designed to compare general revascularization, either PCI or coronary bypass versus medical therapy. It was not powered to test whether coronary bypass is superior or non-inferior to PCI. It's completely different design compared to the Syntax. Syntax was purely designed to compare coronary bypass surgery versus PCI. However, ischemia, it was different. So that one of the criticism for the downgrade to the guidelines, because surgeon would believe that ischemia trial was designed to compare PCI versus medical therapy. And the outcomes for this trial was not significant. So those who underwent revascularization PCI, those who had stable, just to make it clear, the patient who had a stable ischemic coronary artery disease, who had moderate to severe ischemia, they compare those who underwent a coronary angiogram plus PCI, like intervention, versus those who underwent only medical treatment. No significant difference. The other things, the criticism for this downgrade, there was a complete ignorance of the Syntax trial, Excel, and Noble trial, which all were designed, well-designed randomized control trial to compare coronary bypass surgery versus PCI. And all Excel and Noble show superior outcomes or superior results for coronary bypass versus PCI, and yet they ignored all those trials in the guidelines, and they insist to downgrade the coronary bypass surgery recommendation in patient with three-vessel disease, and they're referring to the ischemia trial, which is absolutely not powered to test coronary bypass versus PCI in this group of patients. So I would recommend you guys to read the guidelines, and not only to read the table, also the discussion, and to see according to each recommendation, why this recommendation is based on what. We know it's class 1 indication based on which randomized control trials. This will help you in the discussion to advocate for the patient. For example, if one of the cardiologists would advocate to do a complete revascularization by PCI in patient with three-vessel disease, despite the they guys understand how to defend and how to I'm not gonna say argue, but how to explain or to support your answer. Any questions?
Thank you so much, Dr. Mariam. This is Mohammed. Dr. Mariam, if I may ask, now the earliest Syntax trial was intended to study to compare or to prove non-inferiority of PCI compared to CABG.
That's true.
And the follow-up now in 5 years and 10 years, would they still was intended to prove non-inferiority, or it has been changed to prove superiority, or what is it?
So it was designed to be a non-inferiority trial. However, based on the results, this coronary bypass surgery shows significantly superior to a PCI. But it was designed as a non-inferiority trial.
See, thank you so much.
So again, I would encourage you guys all to read the new guidelines. It's very important for those who's gonna write their exam. I know for the Canadian board, and I can guarantee that this question will appear in the exam. How would you argue against the new guidelines? So you'd have to explain if you agree or you disagree with the guidelines, and how did they downgrade. So you'd have to mention the ischemia trials, you have to mention the other randomized as Excel, Noble, and the syntax trials, and how they're superior. And you have to, just to support your answer with those trials. So you guys have to understand how important, it's important to have a guidelines to guide us as a cardiac surgeon into which is the best treatment for the patient. But again, we have to understand based on what those guidelines are written, and do they make sense or not to us? Because nowadays we've noticed to see there's a lot of biases when they write the guidelines. The guidelines, if you go and see for the 2021 guidelines, it's absolutely written like almost 100% of all the authors of the guidelines are cardiologists, and the practice in the state is the gatekeeper for the guidelines are the cardiologists. So they sometimes, unfortunately, they manipulate the guidelines to their benefit.
Thank you, Doctor.
Okay. You're welcome. So this session was intended to be for the R7. I thought we would have more R7s for today's session to have it more interactive, but thank you for those who participated. It's very important, very landmark trials. You guys all have to know, not only be familiar with this trial, but you have to know it from inside out, and you have to understand what's the primary endpoint, what's the criticism for this trial, how does this trial affect the guidelines, and the hint about the new guidelines and how to defend the new guidelines.
Mariam, thank you so much. I guess this marks the first of its kind of reviews that you and a group of colleagues, surgeons, will be joining you as a last session for those Thursday's activities. Did you decide if next week will be case scenarios and mock exam type of questions, or have you decided anything else?
Yeah, so what we thought is we do a club, like a trial, like once a month, and the other session would be a case scenario. So like adult case scenario, whatever, gonna be surprised. We'll pick one of the R7 and we'll guide them through the case. It's going to be like exam, similar to the oral exam.
Okay, so for the group, next week will be a scenario or maybe two scenarios with some mock type of questions, exam type of questions. Thank you so much again, Mariam. It was a pleasure listening to you and steering the neurons, I guess, in our heads. Thank you very much. And thank you guys for coming. Bye.
Thank you, Dr. Khouria.